I've worked at the Center for Telehealth for 6 years now. Just for some background about who I am and my role, so you have some context of what sorts of questions and such that I'm ready to answer. I'll try to answer all of them, but I am a social worker by background and have worked most of my career in kind of public health or research settings. So worked for a while at a FQHC doing I was a study therapist working in HIV and substance use for a while, and got a lot of exposure to NIH grants and really worked a lot in the research side of things. And then moved over and started doing more education and training around the time when the Affordable Care Act came out. So got a fair amount of policy did a little bit of policy and education work there. And then when we moved to MUSC, or moved to Charleston, I landed this great job. I was looking for roles that touched on health equity, public health, and landed at the Center for Telehealth. And you'll see it's a very mission-driven place and has a long history of telehealth. And I've been very proud to work there, and have a lot of the reflections that I'm sharing. Some of them are my reflections, but some of them are the reflections of my colleagues. It was fun putting this presentation together and really thinking about the last 6 years, because I started in telehealth really in 2017, and the focus, obviously, with COVID and the transition has really changed, and it's been a wild ride. And I'm excited to share some of what we've done. So with that, I won't spend too much time, but I want to share a little bit about our center with you to give you some context, highlighting some of our partnerships and how we've grown to be where we are. Also want to talk a little bit with you all about how we describe our value cases. It kind of goes to what Kathy was speaking to earlier. How do you get that buy-in from leadership to your funders, et cetera? And so I want to share how we've gone about that. And then one of the things I'm most excited about, and that Derek and Laura and the team asked me to speak about, are some of the innovative things that we're trying for the future. And so I cherry-picked a few of my favorite programs. There's a lot more we could talk about, but I'll be sharing those. And then I'm going to talk about some of the lessons learned along the way. We are a center of excellence, like Derek said, so gotta give my funding acknowledgement. All right, so a little bit about the center. Before I kind of dive into this trajectory, just to give you some context to South Carolina, it's a lot smaller, obviously, than Texas. We've got a little over 5 million people there. The Medical University of South Carolina is located in Charleston on the coast. It is one of 2 medical schools in the state. And historically, the Medical University of South Carolina is a state agency, or was, and so we, because of that, as healthcare has grown and acquired other hospitals, we were always just kind of located on the peninsula. And so our telehealth programs really grew focused on other health systems. And you'll see as I talk about some of our decisions around technology and our growth, we were working with hospitals that were on different medical records, that had different staff. We were working with FQHCs and private practices in rural communities, not affiliated with MUSC in any sort of way. So that's really was the history since, and I'll talk more about this, but we have shifted, and in 2018, we started acquiring more hospitals and have really grown into a health system that now includes about, I think, 14 hospitals, some joint ventures, as well as a much broader swath of ambulatory and outpatient settings. But we are the safety net provider in Charleston. We are the only, in terms of subspecialty care, folks are often driving 2 or 3 hours to get to Charleston for that care. So telehealth was always important, given kind of the unique context of South Carolina. Before in 2017, when we applied for our Center of Excellence grant, one of the analyses we did was we looked at all of our different telehealth sites and programs, and I think it was 78% of them were being delivered into HRSA designated rural areas. So our focus and our growth has always been on rural health. All right, so back to the timeline. Really a lot of our telehealth programs we trace back to the early 2000s, and these started largely out of philanthropic and grant-related initiatives. Maternal fetal medicine was one of our first, but we also got a telestroke program off the ground, school-based telehealth, and then an outpatient telepsych program. happy to talk about those early days if you all want, but the main thing that I think is important is these were all very siloed initiatives. They were physician-driven, small scope, but really the focus was health equity. It was getting access out into rural communities, and a lot of really mission-driven folks kind of working individually on this. It wasn't until 2013 that we centralized these efforts into what is now the Center for Telehealth. And the impetus for this was South Carolina, when we chose not to expand Medicaid. Our legislature was trying to think of other ways that they could invest in healthcare access and get a win. And because South Carolina, or the Medical University of South Carolina, had these kind of growing, burgeoning programs of school-based health, telestroke, it seemed like a good option. And so we got an initial one-time $12 million investment to build out a telehealth infrastructure in the state. Part of that, and this is a big, I'll talk a second about it, but part of that, we were mandated to work very closely with other partners in the state. And that is where the South Carolina Telehealth Alliance came from. And so it was an interesting process. We were working with a lot of our competitors. There was a lot of arguments about the funding, how it would get allocated, and it made it increasingly important to have a very clear strategy and to be able to hold folks accountable to the outcomes and try to keep focused and on the goals of the funding as opposed to all the kind of market share and competitive things. But it was a rough 3 or 4 years. I joined the center in 2017, right as we were kind of working our way out of that. And I actually joined as the leader of that coalition of different healthcare organizations. So my initial role was trying to get all of the different players to play nice with each other. In 2017, that is when we got our Center of Excellence. I would say, the initial funding from the state was huge in our ability to expand our programs. A lot of what we do now is also research and innovation. And I would say that, the second big event was getting this HRSA Center of Excellence designation. We now receive $4 million a year, all focused on telehealth research and innovation. And I'll talk more about that. We received that award. It's funded out of the same office that the TRCs, the Telehealth Resource Centers, are funded. The Telehealth Resource Centers have been around for a long time, providing technical assistance to folks getting telehealth off the ground. There was a identified gap, though, at the time of, we have a lot of this work happening, but we don't have robust research and outcomes, really trying to show, does telehealth, can telehealth deliver quality care? What does it do to cost? And so the requirements for this grant were that you had to primarily be providing telehealth into rural communities, you had to be an academic medical center, and you had to have some examples of sustainable funding and business models that have allowed you to kind of succeed. And so that's why we were designated. We got an award from the ATA for working together with all these competitive partners. Then obviously everything changed during COVID. And now I would say we're finally able to breathe and are in this space of kind of pivoting and thinking, what does the future look like now? Especially now that we have payment for a lot of, direct to the patient home care. What can we do with that? And what are other innovative models, remote patient monitoring, et cetera, that we should be exploring? So throughout the presentation, I'm going to throw out some of my lessons learned for you all. But I think one of the things I just want to note is that this journey reflects a lot of mistakes that we've made. And often we will have folks come and visit our center. We host site visits. We love hosting folks because we always learn a lot. We learned a lot from the Texas Tech folks when they visited. But I always think it's really important to highlight that we have received significant amount of funding from the state. We now receive $18 million a year from the state, focused on telemedicine. Of that, over half of that funding goes out to other entities, to the other health systems, to FQHCs. But it has allowed us to make mistakes, to innovate. We are not solely reliant on reimbursement or contractual revenue. So it's really important context as folks are thinking about their own programs, just to know part of why we are and have grown to be where we are is because of that significant investment from the state. And I would say kind of tied to that is that from the early days, our executive leadership, our president, they have been bought in before telehealth was even a thing. And I think part of that comes from us being a state entity and having that mission to advance health equity. They always saw telehealth as key to that. But because of that, they've always pushed us to the fore when asking for funding from the state legislature, when working with our federal lobbyists to kind of increase our Center of Excellence funding, et cetera. It's been always a big key piece of that. So, one of the lessons learned, I would say, is getting that executive buy-in and having, to the extent able, push it forward. And I just heard that TTU is successful in getting some funding from your legislature, which is great. Also, similar to what Kathy said, feel free to ask questions throughout. I got a lot of stuff here, but feel free to interrupt. Otherwise, we can answer them at the end too. So the SCTA, I won't talk about this at length, but this is sort of that coalition that we bring all of the different health systems. We've got a broadband agency. Our Department of Mental Health is very active. Actually, our public television broadcasting state agency is part of it. They do a ton of wonderful films about telehealth to advance patient stories and provider stories. I'm happy to share. I didn't share any, but I'm happy to share some with you all afterwards. But that was written into the legislation that we had to work with them, had to cooperate with them. And so it's been really critical to have an annual strategic plan where we really outline, these are the goals for the year. This is what we're going to try to do to make a dent in community hospitals. This is what we're going to do in the primary care space. This is what we're going to do in the school-based health space. And this is how we're going to spend the money. And so if competitors want to participate or not, they have that choice. But if they are going to get the funding, they have to buy into that strategic plan. They have to participate in our work groups. And all of that is kind of written into their contracts that they get. Similarly, and probably equally important, we have to do quarterly reports to the legislature on all of the outcomes across all of our strategic plans. So we have a lot of accountability built into this. And I would say that that has probably been one of the most important things that have allowed us to move to the place of getting 12.5 million a year. So just to kind of break that down, we started off at 5 million in recurring funds, meaning it was a recurring budget line in the state budget. And that over the last 6 or 7 years has kind of ceiling now at 12.5 million. And then our proviso funds are kind of one-time funds that we get, and we kind of allocate those towards different projects each year. So, but we've been getting around 18.5 million for the last 5 years now. Again, importance of strategy. And I would say for us, again, these early days were rough. It was a lot of bickering, a lot of fighting over the money. And I think I really, our medical director, Jimmy McElligott, always had a vision for health equity and always tried to bring the group back to that. And so I think that was really critical, both in navigating some of these challenging contractual discussions, but also in communicating these tensions to the legislature, because we weren't the only ones talking to them. All of our competitors were also talking, and now it's kind of, we're at a place where there really isn't a lot of bickering and everyone is working together, which is a sign of success. So I would encourage you all to check out our SCTA annual report. Again, sharing these progress and having these annual reports and our quarterly reports have been really critical in increasing our funders. Our government affairs team has actually told us that both our videos that ETV has created and these reports are probably one of the most impactful things over. Doesn't matter if we're saving money. They rather hear a patient story when it's Columbia, which is where our state house is. Okay, Center of Excellence. I mentioned this briefly. I won't go into a lot of depth, but I will just highlight, and this is really where the bulk of my work is focused, less on operations and more on this research space. Since we've gotten this award in 2017, we've produced over 110 peer-reviewed publications in the telehealth space, have gone and presented at conferences and events like this, 230. And then we also have a large swath of technical assistance resources and such. We've got a website. I have it at the end of my presentation. Currently, at the Center of Excellence is funding 55 faculty in various levels of effort, all focused on research and evaluating telehealth. And we've got 22 different projects focused on, teleprep for HIV, doing telehealth with homeless populations, exploring implementation science, looking at different education models. So there's lots of different stuff here that I could speak to if you all want. I will say, I know a lot of you are thinking of ways to fund your program. Some of you are more in operations, but for those of you who are in academia, this Center of Excellence grant was sort of written, the legislation was written for the University of Mississippi, who is the other Center of Excellence. But we fit all the criteria, and at the time, our medical director, Dee Ford, that now leads the Center of Excellence, she's like, we should just do it. We fit it. Let's put our program forward. I think we'd be competitive. And it felt like a shot in the dark, but we got it. And we split the award, and it since has grown, and it's, like I said, changed everything. So again, this might not be as interesting for everyone, but for those who are more on the operations side, this is our org structure. We have over 60 FTE that work in our Center for Telehealth. We have a command center similar to what Kathy has. And this is how we've divided it. I will say, and this is my next thing is, when working in the innovation space, I have been through, since in my 6 years, I've been through 3 different reorgs because it's constantly changing. Programs are coming and sunsetting. And so, as you are thinking about building your own programs, just know that change is inevitable and stuff is going to happen. So I won't go into a lot of depth, but I'll just highlight, we've got a division of folks, a director who leads all of our external engagement with our external partners. They also do a lot of our payer engagement and focus on kind of pulling together all of our competitors around telehealth advocacy. So that's a big arm. Our business operations, I oversee our research and grants, business development, and then the last 3 are really the main kind of nuts and bolts of more clinical operations. So someone who oversees all of the clinical providers and services and managers of different programs, someone focused, and a team, I should say, focused on virtual solutions, and then a team focused on kind of tech deployment and maintenance, et cetera. And our leadership, this has been very important. And a lot of times folks are interested where we fall. So a lot of times telehealth shops fall under IT, but we are actually under the growth pillar of our organization. So we very much see telehealth as an opportunity to expand our reach. And our leadership we have a dyad leadership where Emily War is our administrator, she's a nurse administrator by background, and then our executive medical director. And that's been valuable too. I will say the other thing that has changed a lot as a result of COVID is a move towards more systemness and integrating with our system. So initially, we had our own telehealth credentialing coordinator because credentialing was so complicated. We had our own dedicated telehealth compliance person because compliance is so complicated. We had a representative, we bought down one of our attorneys that did a lot of our legal contracts. We have since, probably starting during the pandemic, have really moved towards integrating into the system. So we're no longer buying down folks from those teams. It's expected that our credentialing department is going to know how to handle telehealth. It's going to require maybe some education and training on our part, but that's an expectation that we have for them. Similar with our legal team and our compliance team. They all have trainings focused on telehealth for each of their departments. So. This, I think, is really helpful. It's TSIM, Telehealth Service Implementation Model. This was something that, I don't know, how many of you are tech IT folks in the room? Okay. Did you ever go through ITIL training by any chance? Okay. So we went through ITIL training. It's a training focused on implementing IT systems. And early on, our previous administrator really said, this is like what we need for telehealth programs. And so we adapted that model. We actually worked with the folks who licensed ITIL and now have kind of a textbook and such. But basically what it is we developed a streamlined program for how to develop a telehealth service. What are all the different check boxes that you need to go through when doing it? And it may seem obvious to folks, but this has been so instrumental in helping us make sure that we are developing reliable programs and high quality programs. I won't go into depth on each of these, but I've got some resources that you guys could access. But basically, we have service coordinators in our center that are solely focused on running a service through this process from beginning to end. They meet with the medical director of a program, or perhaps it's a research project where there's an idea. They strategize what the problem you're going to solve. What's the use case? Let's talk through it. And then they run it through all the development. What are the clinical workflows that need to be put in place? What technology is the best fit for this problem? What are the regulatory considerations? And then what are the KPIs and the clinical outcomes? Let's make sure we nail those down from the outset. And then through the implementation, there's a whole kind of go live process and then debrief process just to make sure everything is going according to plan. That was, like I said, very critical. One of the cardinal rules that we always cite is to avoid starting with technology. We because of our role, we do a lot of consultations with different health systems. And oftentimes there's a vendor that they're excited about. They met at a conference. They've got a lot, really excited about the possibility, and they start there and then try to think about, well, how could we use this to kind of meet needs? And we have always pushed very hard that you start with the problem you're trying to solve. Like, is the issue, specialty access or access to rheumatology? Well, okay, if that's the issue, what are the technologies that we maybe need to think about for this? If it is thinking about, another example would be remote patient monitoring. We've been doing that for a while in some of our research programs, but we started with a vendor that sold us really great, but we learned later on that we were deploying it into a lot of communities that had little to no broadband, had poor internet connectivity, and we actually needed a RPM solution that was cellularly enabled, so that if we're actually going to get these patients' metrics, let's make it cellular. So we had to flip vendors because of that. And part of that was we weren't necessarily thinking about what problem we were trying to solve from the outset. So switching gears a little bit, I'll talk a bit more about kind of our scope and of our services and how we describe them. The first thing I'll just say is that, and this is a lesson that I think have coming up, it's been hard for us to figure out how to concisely describe our programs because they are so broad and they meet different use cases. And we're working with all sorts of different people, similar to what Kathy said. Each one has a different staffing model, a different business model, but it became very apparent to us, it was actually right before COVID, that we needed to better communicate the value that we were bringing to the state. Given the great investment, we needed to better characterize our services in terms of their value case. And so we developed these value-based strategies and how we could fit how our programs could kind of bring value to the state. And it also gave us some direction, and I'll explain this in a little bit more, of how we could direct our funding. Because some of the telehealth projects that we've started and that you may start will never be solely sustainable on just reimbursement and contractual funds. And that's where philanthropy, state legislature, grants can step in. So a big piece of it, and this is really where we started, was a lot of supporting rural hospitals. And so a lot of our services fall into that category. Supporting other businesses and institutions. And maybe I'll briefly note that, like, for our hospital support, we have contractual arrangements for our telestroke program and our different programs where hospitals pay us to have that service. But kind of thinking about a health equity and kind of the goal of this funding, we do a tiered system based on the bed size and the rurality to charge hospitals different rates for the service, and try to subsidize more rural hospitals that may not have same access to funding. Business and institutions, this is more of that employer-based care. So we provide our virtual urgent care program to a number of agencies and businesses across the state that they buy that from us. Similarly, we contract with Clemson and College of Charleston, two large universities. They buy our psychiatry for us. And so this is another revenue source where we're bringing in money just from kind of relationships with businesses. MUSC service extension, this is largely ambulatory virtual care, thinking about just ways that we can better extend our services out into the community. Convenient care is where virtual urgent care fits in. Health equity, I'd say this is probably our biggest bucket of programs that we feel most compelled to continue to fund using state dollars. We are working as our programs grow, we are trying to make most of our programs sustainable on either contractual or reimbursement revenue. But we acknowledge that a lot of the funding came to us for health equity. School-based telehealth is never going to have the volumes, the payment, to be fully sustainable, probably. So we acknowledge that we're going to need to subsidize that with state dollars. Population engagement, thinking about remote patient monitoring, ACO population, et cetera. And then primary care support is one I'm particularly passionate about. We know that in rural communities, a lot of folks are getting the majority of their care, whether it's mental health or other care in the setting, in the primary care setting. So how can we better support those primary care practices as access points for behavioral health? How can we support those primary care providers who are already busy and taxed in better serving their patients' needs? And I'll share a little bit about some of the innovation we're doing in that space. Okay, I already said those things, but just to highlight them. Some things will never be sustainable. It's been important for us to start diversifying our portfolio, bringing in contractual revenue, optimizing our reimbursement. So diverse funding is critical. This is a very hard, I don't know if it's hard for you to read, it looks kind of hard for me to read. So in the spirit of trying to concisely capture all of our services, our team developed this wheel of services that really broke it down in a different way. So if the previous slide is more focused on value, this is more kind of use cases in different settings. And part of why we needed to do this is just internally, especially as IT starts to kind of ramp up their digital transformation, there's just a lot of cooks in the kitchen. And so it was really important for us to really clarify what are all of our solutions, what are all of the spaces we're working in, and what is the scope. And so I'm going to dive into a few of these in more in depth, but I'll just kind of quickly run the gamut and say, you know, on the inpatient setting, we have a tele-ICU. It's a partnership that we have with a larger tele-ICU company, but our intensivists and our ICU nurses actually take shifts with that company. They're actually monitoring some hospitals here in Texas. In addition, they always get our South Carolina hospitals, but when they're on shift, they also cover other folks. But this has been a really important service in helping kind of reduce improve leapfrog scores. We've seen reduced length of stay, have really good stats around kind of decreased mortality. So that's a program, can talk more about. I'd say the bulk of our hospital work, though, is really in the consultative efforts. So I'm going to talk more about hospitalists in a bit, but we have a very robust telestroke program that's been operating for a long time. Also inpatient psych, infectious disease, and palliative care programs where we're all consulting. And again, a lot of this is to our own MUSC acquired entities, but a lot of it is also to community hospitals that are not affiliated with MUSC. So it's required us to kind of develop some workflow workarounds using our platform, which we use Teledoc right now for that. But shifting to population health, we've got over 100 schools in our school-based telehealth program. It's primarily been primary care, but the state just gave us additional $1.5 million this past year to build out a mental health infrastructure. And we are partnering with Department of Psychiatry to build up some workforce to plug into that. And so there's different considerations when you're layering on mental health in a school-based setting. And so that's going to be a big effort for this next year. We're actually hoping to chat more with the Texas Tech team because I know they have a pretty robust school-based mental health program. Then into the RTM, RPM space, so remote patient monitoring, we have not figured out payment yet either. I know Kathy mentioned that. We do have a long-standing program that's been grant funded that has focused on FQHCs and free clinics in the state. And that was the program I was mentioning where we provide cellularly enabled devices. It's got amazing outcomes, bringing down folks' A1Cs, 2 or 3 points. It's a high needs, high risk population. So it's one of the programs we will continue to fund using those health equity dollars. But currently, we are also in the process of looking at both our ACO population and also identifying those really high risk patients in our own MUSC and are trying to start dropping the bills. But as Kathy mentioned, it's current state, it's pretty rough. Then in the ambulatory space, there's a lot of programs going on. We also have a virtual urgent care program that is an asynchronous program first, largely. There is a video component, but I think it's only about 5% actually opt for video. And so this is more of like a survey that folks fill out. But we staff that with PA fellows, which is kind of an innovative model and a cost-efficient model. And that also is a great program that we fund partly by selling it off to other institutions. So Clemson participates in our model and they give it out to their employees for free. College of Charleston all of state employees in South Carolina have access to this virtual urgent care platform for no cost. We are currently in the process of developing e-consult, so provider to provider asynchronous consultation. We have a small program that's focused more on free clinics and FQHCs that has been hard to get off the ground, but we're really excited and are just going live this month with a big partnership with our South Carolina Department of Corrections, where they're gonna be doing e-consults with our specialist providers to try to reduce kind of the costly transfers that come when you have to transfer inmates to specialty facilities. Primary care support, again, supporting community providers. We've got 50 to 80, some of them aren't referring as often, but we have a long-standing program where we were providing, gotta check my time, where we are providing telepsychiatry and nutrition were the main asks we actually tried to start with a lot more specialty care, but we were only getting referrals for nutrition and psychiatry. And so we ended up reducing and just do that. And I think we see about 1,700 visits in a month where patients are getting referred from their primary care provider. They used to, pre-COVID, have to go in and they'd go do their visit from a cart from the office because that's how we could get payment. But now they're doing it directly from the home. We are in the process of flipping that model to a collaborative care model, which I'll talk about in a second and I'm excited about. And the last one is all of the ambulatory visits that are happening. So specialty primary care just directly into the patient's home, which really burgeoned during COVID. So that is a lot. Again, I think for us, I'm struggling right now. Finding ways to concisely describe all of the work that's happening has been a challenge for us, but it's important to think about different settings and who. I would say the other thing that this maybe kind of reflects here is that because initially we started as a center that was focused on health systems that were not part of our health system, we had to incorporate that into our technology decisions, into the platforms that we used. And so we ended up having a very intentionally fragmented technology approach, which was fine pre-COVID, but now that we are seeing the level and the scale of visits post-COVID and during COVID, we've had to shift our approach and think more critically. And we've partnered with a company named Andor. I don't get any funding for saying that, but Andor, who we are working with for most of this and trying to get more integrated with our EMR. There's a lot of data analytics. I can talk more about that as a pain point later on. But that has been an important move as we have sought to embrace more systemness, as we have brought in more hospitals into our own network, and as digital transformation is kind of moving all organizations forward. Okay, so next I get to talk about some of my favorite programs. Innovating for the future. So as Kathy was mentioning, virtual visits really took off during the pandemic. But we're at a place now as we exit the PHE and think about the future of healthcare. There's a lot of questions about what is the role for this. Kathy brought up some of them, but first of all, how do we maintain these benefits? How do we ensure that providers, obviously there was a lot more access that was obtained, patient satisfaction, some provider satisfaction. How do we keep those benefits? What's the right mix of telehealth versus in-person? How does that vary from specialty to specialty? How do we build workforce models that really support efficient use of telehealth? And then a big piece of it too is, telehealth has always, or historically, has really been a means to extend access largely to rural communities that did not have access. Well, now that it is ubiquitous, a lot of the social determinants of health that create many of the health equity issues we're all aware of are now playing a role in telehealth as well. And so with this digital divide, how do we try to design programs that really take equity into consideration from the outset and don't further exacerbate health inequities that exist? And then the last is kind of the next step beyond that. How can we extend this to maybe create virtual only practices and to rethink access and try to make a dent in how folks get access to specialty care? So a few things in this space that I want to touch on. First, again, this points to the importance of executive leadership, but we all have pillar goals that we are responsible for. Our pay for performance is tied to it. And so in 2021, the executive leadership team said each department has to set a goal of how much virtual care they're going to continue to provide. And you're going to get, your pay for performance is going to get judged by that. And we also kind of proposed in terms of our patient access metrics, these are all the things that we think that virtual care can do. And we wanted to build tools so that the various departments could dive into their data and understand what is the impact telehealth is having on new patient recruitment. What is the impact telehealth is having on our growth across different regions? What about patient satisfaction, visit loss, provider productivity, and overall contribution to margin? So one of the things that we did was, and it was a lot of pain, but we developed some dashboards that allowed providers and department leadership to actually look into their metrics and kind of explore, well, what does my in-person visit loss look like compared to my tele-visit loss? And what does my rate of new patient visits look like in tele versus non-tele? And so providing that transparency was important, but also requiring that leaders take this goal on themselves and that their pay is tied to it really signaled that virtual care is here to stay, and we want you to think critically about that. Again, executive leadership is critical. Then tied with that, we during COVID were using a video client that was web-based, it was unintegrated, very easy to use, but we knew that that was not the future, right? The future of telehealth and this care is pulling in AI, pulling in the EHR, having more patient-tailored experience. And so we decided to flip platforms, and some of the features that were important were a patient-facing bot, assistance, help with the consent and registration process, workflow dashboard for our TCS team, which I'll talk about in a second, and then on-demand functionality so that if things fall through, it wouldn't just solely be based on the schedule. And then in the future, I think some of the things that we haven't gotten there yet, but we are looking towards is some of those AI opportunities to better tailor the experience to the patient, and then also thinking about the discharge or care planning post outpatient visit. Like, are there things like querying whether the patient has a flu shot? That's probably a pre-thing that could get brought into the visit. But post, is there a way that we can incorporate a better care plan for the patient that pulls in other aspects of their medical record? And this platform, in addition to our direct-to-consumer, we're also using it with our RPM and our school-based program, and are trying to get more and more programs incorporated into it. So on the flip side, we knew that this transition was going to be a ton of change management with our providers. There's going to be a lot of work. And we set up a support team within our Center for Telehealth for a few reasons. One was to help provide support to the providers. Another was we were learning that there was such a disparate workflow across all of our departments that patients were having a different virtual experience if they were going to endocrinology versus primary care versus oncology. Every experience was different. They were using different platforms and different medical assistants that were maybe helping room the patient would operate differently. So as we rolled this new software out, we also rolled out a centralized support team. In current state, that team has 4 CMAs on it, and it's overseen by a nurse manager. They call every patient that has a virtual visit and does a pre-visit check-in with them to make sure they're set up, they know what they're doing. They support the remote intake process for and registration process, make sure all of that has gotten captured. Some of it the bot handles, but there's other things that require a CMA to do. And then importantly, really supports patients who are having technical difficulty connecting to their visit. And so that's where the dashboard on the platform dashboard, our TCS team is able to look at a full clinic and they can see patient by patient whether they've arrived in the virtual room or not. And if they haven't, they can kind of figure out, do I need to intervene or do something to kind of get them into that virtual room? And then on the other side, there's the provider support. So every clinic that we have rolled this out to has an asynchronous Teams chat that the nurse manager and practice manager kind of sit on. And so if there's an issue, our team is monitoring that chat and they can communicate with the providers. If a provider is running late, they can let us know so that they can in turn let the patient know. And then troubleshooting technology for the provider as well. And then if a patient needs to reschedule, they handle that. So this is really, some of the research that we're doing on this is looking at like timestamps and actually costing it out and seeing if this is cheaper. And we are seeing that it is similar, if not more cost effective. I think as we continue to scale, it will become increasingly cost effective. But patient satisfaction, provider satisfaction has gone up quite a bit. So this is just performance, just a few charts. On the bottom right is more just kind of volumes. You can see on a given day, this is how many kind of virtual visits are getting triaged and managed. And then on the left, that is the growth of programs. So the light blue is programs that aren't on Andor and don't have the support. And you can see that it's been ramping up and we are slowly rolling it out. Again, huge change management process over all these clinics. I think from a quality or maybe more of a finance standpoint, one of the most important things is that you can see that visit loss is decreasing by 2 or 3 percentage points for those patients that are getting that additional support from the TCS team. Because of how much change management was involved in this process, the operations team actually developed this quality improvement wheel. And really, and I share it with you because I think it can get applied to a lot of programs, but across all of these are all the different factors that the team kind of identified as playing an important role to a timely, safe patient encounter. And so across each of these, they identified in 2-week sprints process improvement. So what in the team communication, let's set up those asynchronous Teams chats, let's do X, Y, and Z. And then they had spotlight or stoplight reports for all of those. So as you all think about change management, this has been really helpful for us, and it's accompanied with like action lists under each of these spoke items and stoplight reports. But trying to tackle all of these different topic areas in 2-week sprints is really what allowed us to kind of roll this very new software out across so many different practices so quickly. And then the other thing I'd say is that this is why this program is also important, is because it was partially designed to address some of the health equity concerns. Knowing that there are some patients who do not feel comfortable with a telehealth visit or may have connection issues, we do not want to lose them or have them lose this access opportunity. So providing a person-to-person relational support that can really help patients get into their visit has been critical. Okay, so that circle is off because I ended up I flew from Chicago last night, and so I had I got diverted because of weather, and I had 3 connecting flights. So it gave me a lot of time to twiddle with my things, and I forgot to. So this is a result of that. But anyway, that circle is supposed to be below telehealth for specialty care. So this is a new program that we just launched in October, or I think October through December. On the left-hand side, that's where you would go to get your virtual urgent care visit. This is a new program where we have hired virtual-only endocrinologist and a virtual-only rheumatologist, because those specialties in particular for our system are seeing 70 to 80 day lag time before you can get in to see them. So we knew that this is a problem, and we had to address the issue. Additionally, I'll go to this slide. Additionally, we knew that hiring a physician into our university practice group is a very entailed process, involves getting provost sign off because they become faculty. And so we created a new arrangement as we've grown and have acquired community hospitals. We have a community practice group. So we actually hired these physicians through our community practice group because it paid a little better. It was a more streamlined, quick process. And those folks were onboarded and went live early this year. And I mean, all of these metrics are valuable, but I think if you look down at the bottom, we are seeing patients in 3 days for endo and 4 days for rheum. Now, obviously, there are certain things like labs and stuff that will end up having to get referred out to a community provider. Another big challenge has been really knowing that it's not going to always be virtual only, and there will likely have to be some in-person visits, that we had to create some partnerships and collaborations between those departments. But we really saw this as critical, and it was pushed from executive leadership that something needs to happen. And because of that, patients are now getting seen in much quicker time. And we are starting to look at revenue, and between labs and other things, it's sustaining itself. So we're really excited about this. And next up, we're looking at benign hematology with a sickle cell focus, because we have a big sickle cell is very large in South Carolina, and then neurology. And then the next step is to start thinking about virtual primary care first.
Right.
Yeah.
It's very interesting, and congratulations reducing the weight. But do you need a PCP consultation? Is that how you?
There's no referral process, so it's a direct access, which was one of the things as well. I will say that I don't know if it's on there. So there's self-scheduling, which is no referral. So that's how many patients have just found it on their own or through our advertising. But what we did is, to get our initial volume, is we ran a report of all the patient appointments, and for patients who we thought it may be a good fit, contact them, see if it was an option. And I don't know exactly if it's on here. I don't want to, but I would say I think it was like 40 to 50% of patients wanted this virtual visit as an option, just to get in sooner as opposed to waiting.
Do you have problem with payment though? Because sometimes it's required to have a PCP referral prior to using this specialty.
I could not speak exactly to that. We have not, I don't think we may not have built the model around that payment, or we may kind of be upfront with patients about that from the outset. I'm not quite sure, but that's a good question. Yeah, go ahead. Yep. Yeah, that's a great question. So they picked specialties that were identified as maybe more amenable to a virtual visit from the outset, and that maybe involve a lot of lab reading and such. So that was one piece of it. When they did the patient list review, that was a process where they looked at kind of what folks were coming in and presenting with, to make some decisions around that. And then I think there is probably some level of kind of being out front with folks at the start of the visit that, you know, they may, and that's what we do with our virtual urgent care and all of our programs, that, you know, if this is not seen appropriately, we'll have to refer you to in-person care. And so I think, but for the most part, because it's labs, it's not necessarily hands-on evaluation, it's been really amenable to that. Again, I apologize. This is probably one that's a little more outside of my wheelhouse, but I'm happy to follow up with any questions. Emily War has really kind of piloted this. So if folks, at the end, my email is up. Any questions at all about this, happy to share more. Okay. Yes, I mentioned this, the challenge of hiring. Okay. So this is telehealth. So as I mentioned, we've got this whole area of focus on primary care providers and how can we best support them in providing their care. Particular interest is behavioral health. Nutrition has certainly been a referral, but behavioral health by far is our biggest referral. There's huge wait times. Most patients in rural communities get their care get their behavioral health care in primary care. So a big question we have, partly because we have this longstanding telepsychiatry program that cannot meet the demand. A lot of our primary care providers are wanting more med management and more care management of their patients. And it's not working for, you know, our psychiatrists just to do like a visit with them every 3 or 4 months. So this is one of the spaces that we're really trying to innovate in. Similarly, just for background, the other program I'm going to talk about is maternal mental health. And we know that maternal mental health and substance use are one of the highest causes of, or the highest cause of maternal mortality in the perinatal period. And so, but it's preventable through screening. And so I'm going to tell you about a really exciting program that we are launching, or it's been launched, but that has some exciting outcomes. So the first is telehealth enabled collaborative care. So anyone familiar with the collaborative care model? Okay. Yeah. So it's a psychiatric collaborative care model that came out of the University of Washington. Basically the model, and Texas in I looked this up before I came, but I think last year you all just passed payment for it, because not all states pay. South Carolina Medicaid does not pay, but it's a Medicare covered service, and it's billed under the primary care provider. So primary care provider either refers, or there's population-based screening like a PHQ-9 depression screening or a GAD-7 anxiety screening. And any patient who either is referred from the provider or maybe meets a certain threshold gets referred to a care manager. And that care manager is often, it can be a social worker, it can be a nurse, it can be bachelor's level with certain training and oversight, but they work with the patient they work with the patient around more like case management and care management. But then they also meet with a psychiatrist on a weekly basis, and they review a registry of patients. And so it's a really efficient use of psychiatry, where a care manager can have a caseload of about 70 patients, depending on acuity, and they only need about 2 hours of a psychiatrist to cover that level of a caseload. The psychiatrist will review the treatment plans for those patients that the care manager develops, but more importantly, they review the PCP's medications prescription and provide recommendations. So often if a patient isn't improving, or they have, you know, there are medications that are, you know, the PCPs aren't always comfortable prescribing certain psychotropic meds. So the psychiatrist gives recommendations, and the care manager sort of powers the whole thing, communicates back to the PCP, et cetera. So it's probably one of the most researched and evidence-based behavioral health interventions in primary care context. But a lot of rural communities cannot afford a full-time care manager in their practice, right? So this is where we think telehealth can come in and play a big role. So we have hired, in this pilot project, we've hired a care manager that works remotely, and she is supporting 4 rural health clinics and their primary care providers. We did focus groups with them, heading up the stories that they shared about wait times, about patient, just like feeling at a loss, not knowing how to help these patients because the acuity is so high, but it's a 3-month wait at our Department of Mental Health just to get a psychiatry appointment. So So we've hired this care manager. We're piloting it in 4 rural clinics. We've just enrolled 25 patients already. And the feedback is just flooding in from the PCPs about how helpful this has been, how they feel so supported having a care manager that they can just refer their patients to, not have to knows we'll be following up with them and that the onus isn't on them or their nurse to follow up with them. And I'll add that the other layer of this is we're layering on an app-based component with a vendor partner, NeuroFlow, that really provides a lot of psychoeducation and support for the patient and enables more. It also administers all of the PHQ. So it's one of those examples of making the care manager's role is made a lot more efficient, and they can actually manage more patients because of the technology. It also flags any patients that are reporting suicidality so that the care manager knows to call them. So a lot of great features. And that's NeuroFlow. I'll just say they were built specifically for collaborative care management. I think it's a good example of starting with the problem. A lot of the reasons why clinics have a hard time implementing collaborative care is the registry process, all of the requirements around having to do a monthly assessment, having to track minutes. And this platform was built specifically for collaborative care. So a good example of that. I know I'm running short on time and I want to leave time for questions. So I'm going to zip through some of these, but I'll just say another program is Listening to Women and Postpartum People, which is a text-based screener. I'll just show this rather than administering the evidence-based screeners that are called for in peripartum care. We know that there's low rates of actual compliance with that recommendation, as seen there. So we developed a program where everyone getting care at MUSC gets a text-based screener instead of having an in-person screener. And what you see here is the rates of treatment for screening. And so if you think about it, first it's rates of screening, and then it's rates of getting referred to treatment, and then it's actually going to treatment. So in standard of care, you can see there on the left, the rates of receiving treatment, and this is broken down by race. And so 2 things I want to point out is one is we're at almost a 90% rate of getting treatment for folks that screen positive in this text-based program that doesn't rely on persons. And we've eliminated the racial disparity that we saw in the in-person care. So this is now turned into 2 PCORI grants, and there's a lot of research behind it. The thing I'll note here is that they did qualitative interviews with patients. Initially, they were wanting to do apps, but patients highly said, we don't want to download another app, we want texting. So sometimes simpler is best. Okay, last one, because this one also is very exciting to me. Rural hospital, obviously a lot of stuff happening in this space. I'll just note that that top quote, 136 rural hospitals closed in the US in the last 11 years. That's probably no surprise for this group. And 27% of South Carolinians live in rural areas. So this is an important topic for us. This just shows kind of the growth of MUSC real quick. So in 2016, that's where we're located. And we had a number of affiliates. We didn't have any ownership or joint ventures, just affiliates. And this is what we look like now in terms of owned hospitals, joint ventures, formal affiliates, et cetera. So these are the ones we own. I'm gonna talk about a partnership real quick with Hampton Regional, which is an affiliate of ours. So in that general area, there was a hospital in Bamberg and some of the surrounding counties that closed. So it's one of the few remaining hospitals. The hospital has very poor outcomes. And in 2019, around 85% of residents that lived in that area were getting their care outside of that facility. And they only had an occupancy rate of 30 to 40%. So obviously big economic drivers into how that hospital is going to stay solvent. We entered into a partnership with them that was highly telehealth powered. So some outpatient services, a lot of the inpatient services that we provide, and then telehospitalist rounding, which is what I'm going to talk a little bit about. So that model, we have a hospitalist that rounds on every patient that is admitted in that hospital every morning. There's APPs that are actually on site that they meet with, and then the hospitalists are also on call. I could talk about data later. So this is what we have seen as a result, and just some data. So first of all, ER transfers have remained pretty steady, but ER admits into the hospitals has risen. And the ER transfers relate to, you can see here that total inpatient admits have jumped dramatically because the staff feel more comfortable with that hospitalist support. Looking at average daily census, you see an increase there. And then in addition, case mix index, the patients that are getting cared for are also sicker, which leads to payment implications. And then transfers, so decrease in transfers overall from inpatient, both number and percent of transfers. And then lastly, huge performance in terms of 30-day readmissions as well. And one of the things that came out from some rankings that our state does is that we were ranked number 1 of 21, or this program, or Hampton was ranked 21 among similar sized hospitals. And then lastly, if you look at out migration, number of folks that have left to get care. So I know I zipped through that. All of that is probably worth a whole talk in and of itself, but future directions, we just opened a brand new facility. There were 2 hospitals in 2 of our counties. One was destroyed by one of the hurricanes, and the other one was small, and the facility was kind of falling apart. So both of those closed, and this was built in its place in between those 2 counties. And it was built with telehealth in mind. So telehealth in all of the rooms. The staff are all trained in telehealth. We actually have a separate HRSA workforce grant that's focused on working with tech colleges in the community and helping train them in telehealth and teach them about what does it mean to be a telepresenter, what does it mean to maybe be an APP doing telehealth. And this program is just open, but they have the highest quality metrics of all of the hospitals in our network right now. So anyway, that is that. I zipped through this. I'd say, with telehealth partnerships, rural and community hospitals have the opportunity not just to stay open, but to thrive. I summarized all of my lessons throughout. I think the last 2, the reality is, I shouldn't say this here, but I personally, telehealth and technology and stuff is not my thing. I don't really care that much about it. But what I do care about is health equity, and I care about patients getting care. And I have, my first week being at the Center for Telehealth, I was learning about our telestroke program. And Dr. Christine Homestead, medical director, she was presenting on something, and she got a stroke call. She pulled me in. She's like, "Hey, why don't you just come with me?" And so I sat with her in one of our consult rooms and watched her give care to a patient, 2 hours away, in a rural small facility. The patient was crying. You could see the family was, she was supporting the family. That patient got TPA in great time. But I was able to see it all happen. And that's what I care about. It's less the technology and more that lives are being changed. Healthcare is being extended. And, like Kathy mentioned, we need to innovate because healthcare is too expensive and access is so poor. And so something needs to change. And I think there are so many opportunities with telehealth. So for me, it's important to stay connected into that why, as opposed to not caring so much about what vendor is doing what. And then lastly, I'd say surround yourself with good people. So these are a lot of the folks that I work with on a regular basis, a lot of the researchers whose data I'm sharing, and then some of my support team who supports me. So a lot. What questions do y'all have? And I will say I don't have physical cards. But I do have an email address up here. So feel free to shoot me an email, take a picture, and then that COE is where we post a lot of our research products and peer-reviewed papers. So.
It's very challenging to try to summarize so much work over such a long period in such a short time. So thank you for at least attempting that. Do we have some questions?
Ryan, I really appreciate that this telehealth center is grounded in health equity to reach out to the vulnerable amongst us, and specifically your rural population in South Carolina, which I think is very much our direction with the Texas Tech Telehealth Institute. So 2 questions. Could you expand a little bit more about your community practice of clinicians that you have as far as billing for those physicians and perhaps malpractice coverage? Because I think it's apparent to us that if we're going to do something similar to the impact that MUSC has done, we have to increase our workforce. And the idea, how do we go about doing that efficiently and quickly and in a sustainable model? The second question that I had is, how do we, as Texas Tech, we don't own most of these facilities, we're relying upon collaboration. So how do we come across that we're not trying to take the piece of the pie of these rural facilities that are on a very low profit to loss margin? So 2 questions there. And again, thank you.
So for the first one, I probably can't speak as much to the malpractice, but I can get some follow-up information. You know, in terms of MCP or MUSC community physicians, they bill as a separate entity from our other physician group. And I don't know beyond that what else what further, and I don't know enough about billing. So I can refer you to the folks to answer that. But to your second question, there's a few thoughts come to mind. Well, maybe before, I will say one of the things that has been interesting is we've had a hard time recruiting. Charleston's beautiful. People want to come to Charleston. But even so, we've had a hard time recruiting specialty physicians. For these virtual only, we have to shut down the application portal after a week because we have so many people who are interested in doing virtual only. So I think where specialty care is, especially often in rural communities where it may be harder to draw folks, it's been really valuable for us. I think our rheumatologist lives in Massachusetts. The other one actually does live in South Carolina, the endocrinologist. But in terms of recruiting, it's been huge and helpful for us. And I can follow up with you on the others. But for the engagement with other facilities, I think a few things are important. Early on, it was really important for us, both in the data that we were producing, but also in our conversations, to showcase that, especially in community hospitals, we're trying to help patients stay where they're at. We're not trying to, they'll lose, a rural hospital is going to gain money if patients are staying there and not getting transferred out, or if the community members feel comfortable getting care there because they have the Texas Tech Health Sciences logo or whatever the entity is. A lot of folks feel a lot of comfort knowing that they're getting care at their local facility, but they have the MUSC brand kind of backing them. So it was important for us to kind of share that data back to them. I think another really critical piece is hitting the ground and actually visiting these practices. Early on, our coordinators were spending a lot of time with sites, training them. I think it makes it a lot easier for folks to have that referral, to feel comfortable reaching out. And then one of the things that has we've seen as a halo effect, and our research has shown this, is our tele-ICU program and our stroke program both have educational components or quality improvement components that they layer on. So all of the 9 hospitals that participate in our tele-ICU, our intensivists actually do kind of grand rounds, quality improvement at those sites with their staff on sepsis, on palliative care, to try to raise up the competency of the local team and also build relationships. So that's been seen as really valuable. And one of the research, our stroke team does something similarly. And one of the research projects that we did was we looked at county level mortality rates, discharge disposition, rates of TPA for stroke survivor or stroke patients. And we looked at counties that had telestroke versus counties that did not have telestroke. And we saw that across the board, regardless of whether the patients themselves got telestroke, at a county level, patients were less likely to die if telestroke was in their community. Patients were less likely to get discharged to a SNF. Patients were more likely to get discharged home and were more likely to receive TPA. And the telestroke piece of that was only about 20% of the patients. It was, there was this halo effect of raising competency in these communities and counties that we see in some of the quality metrics.
Ryan, thanks again. One of your slides, you showed the primary focus, right? Where there is ambulatory care, urgent care, inpatient care, and population health.
Yep.
So from your experience, where are you spending most of your resources? And if you have a sense of, we talked about margins, right? So where you're making or meeting some margins. Yeah, this
Yep.
particular slide.
Yes, great question. So I should maybe for some context, our annual operating budget is around 30 million. And so I mentioned that we get 18 million from the state, about 9 to 10 million goes out. So so just for some kind of big picture numbers, the bulk of the most expensive programs are our hospital programs. Our tele-ICU is a pretty expensive program. We actually subsidize the hospitals that are participating in that program. And again, this is where the state dollars come in. I would say that program is subsidized. Our inpatient programs and consultative programs, those are largely sustainable based on contractual revenue and billing revenue. Then the bulk of it's not our center for telehealth funding. Obviously, the biggest amount of activity is going to be that ambulatory space where we see the biggest volumes, but that is not apart from our centralized support team and the cost of the platform. Those are the only things we're really covering there. So in terms of, I would say ambulatory care, hospital-based consultations, the Zipnosis virtual urgent care, and the e-consult, all of those are pretty sustainable based on the contracts that we have in place and our revenue models, where we are pulling in more of the state support to fund the programs is really in that primary care support space. We do make some money, but it's not. It's definitely a losing program. And then in school-based health, and then RPM, that program it's a lot of NIH dollars and some HRSA funds that we've used for that. I should say on the other side of that 30 million, we also get about 4 to 5 million, 6 million in research funding, some of which goes towards equipment and other things as well. That my main focus and my team's main focus is writing grants and supporting researchers around the state, the enterprise in pursuing grants. So, but yeah, does that answer your question? Okay.
Right. Congratulations again. Since we've visited you, since like the digital ecosystem at MUSC growing further, we were just discussing a while ago regarding, there are a lot of similarity between MUSC and Texas Tech, like, different EMR system, different hospitals and everything. And I mentioned, it seems like very prominent there in the EMR integration, the Andor, the software that you're using. Can you tell us about your experience with Andor? And, is this something you could recommend, or, what is your experience with it?
Yes. I feel uncomfortable recommending a vendor, so I won't do that, but I will tell you a little bit about our experience. They I think maybe just to pull out a little bit, for our stroke programs and our those largely the main source of data sharing is our Teledoc platform. And so the note gets written in that platform and then gets pushed out to the local EHR and then gets put into our Epic. So that's how that platform works. Those aren't discrete fields, so it makes it very hard. We have to pull out of a separate registry to do any analysis looking at that data. Where Andor comes into play and where they sell themselves, and again, I'm less in the virtual solutions place, but they see themselves as sort of a conduit for disparate EHRs speaking to each other, telehealth platforms speaking to each other. They have additionally a lot of AI. They just actually acquired an AI company, and so that's a part of their roadmap for their future. And really, why we went with them were initially the focus was that ambulatory space, the patient-facing bot assistance, helping with registration, kind of being that digital front door to assist patients in. In the process, they also have shared a lot with us about how they build integrations with different types of RPM devices and integrate that into the dashboard, can apply their AI to help decision making, and you know, there's a certain amount of RPM data you want in your EHR and some you probably don't want. And so they help kind of serve as a gatekeeper for that. And so again, this is not really my space, but in general, the amount of integration and the ways that we could pull in multiple products into one solution and create a more seamless experience for patients too, that was another, and providers for that matter, was all very important to us. But I can set up a call with our virtual solutions team too, if you want to dive a little bit deeper. Yeah. Yeah. So we have done, I would say, a fair amount of work in the education space. Each of our colleges have some form of telehealth course integration. Some of them are further along and have it roadmapped in their curriculum, whereas others may have a course. A few things I'll just highlight. We have an interprofessional course that's offered every semester that gets around 12 to 20 students across all of our different colleges, and it's called Interprofessional Telehealth Teams, where they do some case problems, they do some mock calls, etc. Our command center / telehealth center has 2 or 3 kind of showcase rooms where we have different equipment. And so oftentimes we will have different residents or different classes come through and get some demonstrations as part of their coursework. And so really try to use that as kind of learning lab for them. We also use that for a lot of our provider, for programs that are more cart-based or use peripherals, we use that for provider training or telepresenter training. Then, you know, a big component, I would say we are I think there's 5 GME programs that we have a telehealth component that's a part of it. And so that's a course that gives kind of overview of different pieces. And then in general, what I would say is it's very much focused on the different college and the faculty engagement. It's not necessarily an enterprise. While we do have programs in all of our schools, it is not a university-wide common approach. We do have for our internal medicine residents, for our psych residents, and for our peds residents, there are rotations that they do that are telehealth focused. And then for we've got 2 fellowships. We have a nursing APP or psych APP fellowship, or psych nurse NP fellowship, that those psych NPs for 2 years actually support our primary care support, where they're actually the ones doing the teleconsultation into these primary care practices. So that is a fellowship program. And then our PA fellows do a year-long PA fellowship where they're part of our provider pool for our asynchronous virtual urgent care. And then a lot of our family medicine residents actually do precepting at a homeless clinic in town, and they have become increasingly telehealth oriented. And so we actually have a burgeoning family medicine telehealth component that's largely staffed by family medicine residents.